you so much for joining us. Welcome back and welcome to our breakout session. We're excited to have with us Dr. Trisha Scharff, who will be discussing quality of life, the long-term impact of living with cutaneous lymphomas. Dr. Trisha Scharff is a graduate of Northwestern University. She obtained her medical degree from Washington University School of Medicine in St. Louis, Missouri. During her time at Washington University, she also obtained her Master's of Population Health Sciences degree with a focus on applied clinical research. Her research has centered on quality of life in cutaneous lymphomas, the use of immunotherapy in metastatic melanomas, and the treatment of skin cancer precursors to reduce the risk of cutaneous squamous cell carcinomas. She presented 3 international podium presentations on her work at the World Congress for Cutaneous Lymphoma in Barcelona in February of 2020. Dr. Scharff completed her transitional year, including training in intensive care, internal medicine, and surgical subspecialties at Mercy Hospital, and will complete her dermatology residency at Washington University School of Medicine. Before we start and I hand it over to Dr. Scharff, I wanted to remind everyone that we will have Q&A at the end of the presentation, so please use the live Q&A tool in the portal to ask your questions. Thank you for being here with us, Dr. Scharff. We really appreciate it and we're excited to learn what you have to say.
Thank you so much for having me, and it's nice to meet you all virtually. So as you all know, my name is Trisha Scharff. I'm a dermatology resident at Washington University in St. Louis, and I work extensively with Dr. Amy Musick on quality of life in cutaneous T-cell lymphoma. As a medical student, I was actually part of our multidisciplinary CTCL clinic. I have no disclosures. So in practicing dermatology, it becomes very clear early on that the severity of most of our skin diseases is really not easy to assess or easy to communicate. Almost none of the conditions that we treat can be followed by labs, and the patients that we take care of, fortunately, survive instead of dying from their diseases. And we also quickly learned that the visible extent of disease, what we actually see on the skin, often doesn't correlate to how much a patient is disturbed or distressed. And patients with minimal clinical involvement, so not a lot on the skin, may be really distressed, but others with more extensive involvement may not be bothered by it. So the severity of a skin disease is actually related to both its clinical extent, but also its effects on patients' quality of life. So when we talk about quality of life from a scientific point of view, the question is, what do these words and terminologies actually mean? And there's a lot of variability in the terms that are used in this realm. We talk first about health status. And that's pretty self-explanatory, just your current state of health. Similar to that is functional status, so your ability to do your normal activities. And then health-related quality of life, which is what we'll be talking about today and what we tend to study the most, includes health status, but it goes further by including the value that patients attach to their health status. How does it impact them, and what does it mean to them? It's our patients' satisfaction with life in the domains that they consider to be important. And quality of life is best assessed through something called patient-reported outcomes. And those are direct reports from our patients on the state of their health without being filtered through any kind of observer or filtered through a doctor. When we measure, so our group does focus on quality of life in CTCL, specifically mycosis fungoides and Sézary syndrome. And when we measure quality of life, there are generic instruments, and those are used for multiple types of diseases, things like diabetes and kidney disease. And so we can use them to compare CTCL to those other types of diseases. We also have more specific instruments, skin-specific, disease-specific, or CTCL-specific. And those instruments tend to be a lot more sensitive to change in the way that a person is feeling at a given moment in time, because it actually addresses the concerns that a patient is thinking about that's actually on their mind. And unsurprisingly, we found that CTCL has a really profound and pervasive impact on patients' quality of life for various reasons. And the goal for us when we're treating CTCL is generally palliation, making people feel better, not always curing the disease. So quality of life is one of the most important factors to us to consider when we're making our therapeutic decisions. So it makes sense why we as doctors care about quality of life in a clinical setting, because we care about our patients. But the question becomes, why do we have to think about it in such a scientific way? Why do we need all of these structured studies about it? And really, this does go beyond just us wanting to improve outcomes for our patients. It's actually something that the FDA now requires as part of clinical studies. And it's something that they look at very carefully when they're thinking about approving a new medication. There is more and more of this emphasis on patient experience with a drug, rather than just the traditional study endpoints that we used to think about, like just how long you survive without thinking about what your quality of life is like during that time. So that's where this patient experience data comes in. And patient experience data consists of two different arms. First, there's the physical and then the psychosocial impacts of disease. And that includes our signs and symptoms of disease, and then patients' views on how those affect their daily functioning. It's the course of the disease over time, and so how it affects a patient's quality of life over the years. And it also includes patients' experiences with different treatments in the past, the accessibility and convenience of a drug, clinical improvement, and then side effects of a drug. The second arm expands on that a little bit. It's views and preferences on different types of treatment strategies. What needs are still unmet with the treatments that are already available, patients' expectations of how future medications will benefit them, and then, really importantly, patients' views on the trade-offs between side effects and clinical benefit. What is worth it to a patient? And one really strong example of how patient experience data has affected how the FDA approves medications is vorinostat. Vorinostat is a pill medicine. It's FDA approved for CTCL. And the overall response rate for vorinostat, people who ended up becoming completely clear or almost clear with the medication, was 24%. 8 out of 33 patients in the study that they looked at it. And of course, this was a study, it was looking at patients who have failed a lot of therapies. But regardless, when you look at that response rate, it may not be super impressive, right? 1 out of every 4 patients. But one thing that the FDA really liked about vorinostat was that patients had a significant reduction in itch. And the average itch score across these patients went down by 3 points. And there was itch relief even in these patients who didn't have a response in terms of clearing the skin or clearing the blood. So I wanted to go into a little bit about what we do when we study quality of life, as well as some of the data and what we've learned. And we also want to share how we can use that moving forward so we can help you guys as a group of patients. And then what we can do right now before we have all of the data that we need to help us. So what we currently do is hand out a packet of different quality of life questionnaires. Some of the most common quality of life questionnaires we use are these generic instruments that I measured, which again, we use across populations and across diseases. We have these skin-specific instruments that I mentioned. Those are used for different types of skin disease. And that includes the Skindex, and then these different types of itch scales. We also do have one CTCL specific instrument, and that's called the MPHS, mycosis fungoides Sézary syndrome. But I'll talk a little bit more about this instrument a little bit later in this talk. So to start, the HUI3, or the Health Utilities Index, which is part of our survey packet, is a 15-question instrument, and it looks at quality of life in terms of these health utility scores. There are 8 different domains, each has its own subscore. It looks at vision, hearing, speech, ambulation, dexterity, emotion, cognition, and pain. And this is an instrument that can actually tell us about the economic impact of a certain type of disease. The SF36 is also a generic instrument. It also has 8 different domains, and each one has its own subscore. And these are different than the HUI subscores. So there's emotional role limitations, mental health, physical functioning, physical role limitations, pain again, general health, energy, and social functioning. Then the Skindex 29 is the skin-specific instrument that we tend to use the most. It's used in multiple skin conditions. It's been studied extensively. We only have 3 domains here: symptoms, emotions, and functioning. And again, these are on 100-point scales. But unlike the other 2 questionnaires, higher scores indicate a worse quality of life. So just to show you an example here of what one of these surveys looks like. So the SF36 is the most commonly used quality of life questionnaire in research today. It's available online for download. And when you look at these questions individually, you can see that they're pretty general. There are no questions about itch, for example, or about appearance. And those tend to be really big concerns for patients with skin problems. But these generic instruments do address some of these broader issues: emotional problems, functional status, social ability, and ways of interacting with people around you. So it is still a useful tool. One of the first studies that we did in our group was using the Skindex because it's such a commonly used instrument for skin disease. And one of the first things that we found was that while our CTCL patients had a low quality of life across all stages, our late stage patients had a worse quality of life than our early stage patients. So we have early stage in yellow here, late stage in white. And we can see for late stage, we're getting over into the severe category for all of these domains. Again, the higher numbers here are worse. And in symptoms, emotions, and functioning, our advanced stage patients do worse than our early stage patients. And for most people in the audience, this is probably not surprising because we do often see increasing symptoms, especially itch, ulceration, and pain in our later stage patients. But the other thing that we were able to do with the Skindex was not just compare CTCL early stage versus late stage, but also compare our patients with CTCL to patients with other types of skin disease. So you may recognize some of these skin diseases. Vitiligo is an autoimmune condition that causes loss of pigment in the skin and can cause white patches on the skin. Non-melanoma skin cancer is things like basal cell skin cancer, squamous cell skin cancer, just not melanoma. And we see that across stages, our CTCL patients had higher symptom scores, so worse symptoms, and worse function scores than patients with vitiligo and with skin cancer. And they also had higher or worse emotion scores than patients with skin cancer. So here's a slightly longer list of skin conditions that you may recognize. Acne, we know we see all the time. Psoriasis, which causes scaly plaques on the elbows and the knees. Eczema, which causes an itchy rash over the body. Lupus, which is a scarring skin condition, affects the face and the scalp in particular. Dermatomyositis, which causes a skin rash that is sensitive to the sun and also causes muscle weakness. And pemphigus, which causes blisters all over the body, but specifically in the mouth and on the genitals. And when we look at all stage CTCL, all of our patients together, including our early stage patients, they actually did tend to do okay compared to these other skin diseases. But when we looked at our late stage patients, we did not do quite as well. Looking at late stage only, our CTCL patients did worse than acne and psoriasis in every domain: symptoms, emotions, and functioning. They did worse than patients with eczema for both emotions and for functioning. Worse than cutaneous lupus, that scarring skin disease, for symptoms. Worse than dermatomyositis, which again causes muscle weakness for functioning. And worse than pemphigus, which causes blisters all over the body for symptoms and for emotions. So obviously, our late stage patients had a worse quality of life than these other fairly debilitating skin diseases. In another study by our group, we decided to compare our CTCL patients to patients with other types of chronic medical conditions. We used one of our generic quality of life measures, the HUI, or Health Utilities Index, where again, we can look at the economic impact of a disease. And we found that our CTCL patients also score worse than patients with diabetes, patients with end-stage kidney disease, and the larger all cancer patient population. And when we look at cost, both the cost and the quality of life impact of CTCL is similar to patients who are on dialysis. The overall CTCL score on the HUI corresponded to severe disability. So we have all of this information. We're seeing how poorly our patients are doing compared not just to patients with other skin diseases, but also compared to these other chronic medical conditions. And we see this enormous economic impact. So the question becomes, what are the next steps? We know that CTCL is a cancer diagnosis, but it's also an inflammatory skin disease. And so our patients' experience with it is very different than for any other disease. And despite us observing all of these things, we actually have very little formal understanding of patients' experiences that we've gotten through standardized interviews. So the goal of the next study that we performed was to assess whether we're actually measuring what patients want us to measure. And we wanted to look at our late-stage patients and include them as well to see what their concerns are, because they're often excluded from some of these studies. And so we sat down and we talked to our patients. We conducted 18 one-on-one structured interviews with our patients from our multidisciplinary CTCL clinic. Interviews were about 45 minutes long, and it was a total of 13 hours of audio, all of which was reviewed by me to make sure that all of our transcripts were accurate. Came to a total of 500 pages of transcription, all of which I coded line by line. And the themes that came out of that were, number one, problems with psychological and social functioning, dealing with clinical symptoms, and significant treatment burden. So the first and the broadest theme, as I mentioned, was overall psychological functioning. So despite our patients being seen in a really high support, multidisciplinary environment and feeling like they themselves had a pretty good understanding of their disease, there was a total lack of understanding in the community. Because even though CTCL is a cancer, people do not understand it in the same way as they understand breast cancer or colon cancer. There's no media coverage. There's not a lot online about it. And it's really hard to explain to your friends and to your family. And there was also this assumption that this was a disease that was contagious, that they had leprosy or chickenpox. And so they had to get documentation for sports and even for traveling on an airplane. Most of our patients were specifically concerned about their appearance, and one of them described feeling like a leper. The visibility of CTCL as a disease opened our patients up to scrutiny, and they were very aware of that scrutiny and the way that they were perceived by the people around them. And so embarrassment and self-consciousness prevented them from participating in normal activities, including just going out in public. And so our patients felt isolated physically and because people didn't understand what they were going through. And so CTCL affected the way that other people viewed them, but also the way that they viewed themselves. 17 of our patients noted this feeling of otherness, the perception that they were different than other people and not normal. And they just didn't feel like they were themselves anymore. Many of our patients felt hopelessness and depression and experienced a lot of uncertainty about their next treatment or the future course of their disease. One of our patients told us that it was impossible to find joy in each day because as soon as something good would happen, you'd be reminded of this disease and you'd be taken right back down again. They also did talk about clinical symptoms, of course, and all of the concerns associated with that. Not surprisingly, most of our patients experienced pretty severe itch. 2/3 of our patients had pain, and many of them attributed that to skin fissuring and skin sores, breaks in the skin. Skin flaking was also a predominant symptom, and that significantly impacted their social functioning and was very time-consuming. So many of them would slather themselves in Vaseline, have to cover up with socks. Anytime they wanted to change, they would have to undo all of that and redo the whole process again. And overall, all of these symptoms, as well as just worrying about the disease and what was going to happen to them, worked together to interfere with their sleep. And that certainly impacts quality of life overall. And finally, the burden of treating their disease. So in addition to the financial costs of therapy, there was also this indirect cost, having to take time off of work, having to change their routine, and then dealing with side effects. And so even for patients who weren't getting infusions, weren't having to stay in the hospital all day, but even just getting light therapy, they had to schedule these sessions up to 3 times a week when they were starting, plus clinic follow-ups every few months. And this is, of course, only really relevant to patients in the United States. They were fighting with insurance companies. And then side effects themselves could be devastating on their own. So you may remember I mentioned that there is one CTCL specific quality of life questionnaire called the MPHS. So here are the elements and questions that are included in that instrument. And our findings with our study really confirm how important it is to ask these questions. We see lack of understanding, hopelessness and depression, the severity of symptoms, the burden of treatment. But there's still some things that are missing in this survey. And part of the reason why that's the case is that when this instrument was developed, it's unclear whether there were actually any late-stage patients that were included. And even when they were validating this survey, only 8 patients out of 126 patients, so 6%, had late-stage disease. So we really miss out on the concerns that come up when the disease is worse. So some conclusions. Obviously, patients' concern about their appearance is something that sets CTCL apart from other cancers and other chronic conditions. Our patients feel isolated. Their sleep is dramatically affected. And even though the MPHS does ask about the severity of symptoms, those symptoms affect patients in different ways. And so we feel that it's important to address those different symptoms individually, so we can fully capture all of these additional factors that patients feel are important to them and to their lives. So we have this information. We're seeing, again, how poorly our patients are doing. So I talked about earlier the fact that CTCL is a cancer and an inflammatory skin disease. It's not just one thing, but using multiple questionnaires like the survey packet that we use is really time consuming. And it's really burdensome for patients to have to do that every time they come into the clinic. So the take-home point here is that we as a CTCL community that advocates for our patients with CTCL should be developing and using a more specific quality of life tool to measure what our patients actually think is important. And our study highlighted those specific symptoms that we talked about, specific aspects of quality of life that current instruments don't measure. What we need is a single disease-specific, patient-reported quality of life measure that we can use in clinic for all of our patients to assess our patients' quality of life at a moment in time. But then we can also look at the impact of treatment on quality of life over time. And eventually we hope that that can help guide us on the treatments that would work best, not just for skin and blood clearance, but also for improving quality of life for different types of patients. And so that is what we are working on right now. So with the information that we got from this last study and from interviewing our patients, we are finalizing development of a new quality of life CTCL specific questionnaire. And our questions are based on the responses from our existing surveys and from the 13 hours of sitting down and talking to our patients about what is important to them. We want just one questionnaire that they can sit down and complete quickly before they go into their appointments. So again, the question becomes, once we have that instrument that can reliably pick up differences in quality of life, how do we use that to help our patients? So when we talk about wanting to help you guys as patients, one of the things that we look at is survival curves. And I'm not putting this up to cause panic, and also remember that this is coming from 2010, and to capture new survival data can take 10 to 20 years because people do well with this disease and new treatments come out slowly. So that's my disclaimer before I talk about this. But if you look at these survival curves, as you look at this first graph and you move across the graph, the higher a line ends up, the more likely that patients in that group would survive to that time point. So we can see differences most clearly when these curves start to separate out and move farther apart at 30 years from diagnosis. So we start our study here at time 0 and then move out to 30 years. And we see that our early stage patients, so those are the patients at the top of the graph, are ending up at a higher point. So they have a higher probability of survival than our late stage patients. And there's a very clear differentiation between the patients 1A to 2A, early stage patients at the top of this graph, versus late stage 2B to 4B, and those are the patients at the bottom of this graph. And so what that tells us is that priorities for our patients are going to be different based on where they are in the disease spectrum. And of course, these are generalizations, but in general, we know that for our early stage patients who are living with this as a chronic disease, a lot of our treatment decisions really revolve around how sustainable is this with my current lifestyle? I need a treatment that I can be on for years that hopefully eliminates my symptoms, hopefully controls my disease, but that I am able to maintain over the course of my lifetime without interfering with the normal activities that I enjoy. So it really is a lifestyle choice that's sustainable for patients. When we're looking at our late stage patients, we want to look more at what treatment can give us results quickly. What treatment is going to resolve symptoms, not just the disease, and of course, what treatment is actually doable for our patients. So when we think about this, when we think about how we are first going to start treating you, we have two fundamental rules. The first, which incorporates what we talked about today, is we never want to make the treatment worse than the disease. And that's something that we can track and something that we're talking about with these quality of life questionnaires. And the second thing that we think about, a lot of times we like to use these immunomodulator medications, and we're very fortunate to have them. And these are medications that shift your immune system's response to the cancer before we actually immunosuppress you. When we think of immunosuppression, we're talking about some of these more traditional chemotherapies that you think of patients getting when they have breast cancer or colon cancer. But for the purposes of this talk, the purposes of thinking about quality of life, really the first is the most important here. So we do have a couple examples of how we might choose a therapy based on a patient's priorities. With our early stage patients, I think about narrow band phototherapy or light therapy and topical nitrogen mustard or mechlorethamine. And those really do tend to be equivalent choices for many of our patients. So why might you choose one over the other? So for phototherapy, narrow band UVB, you're coming in 3 times a week to get it done, or you use a light unit at home. So there are a lot of considerations to think about there. Patients might live too far away from a phototherapy center to make that practical. It could interfere with work. And again, home units are an option, but they may not be covered by insurance, or our patients may not be able to afford them. When we look at nitrogen mustard, it can be applied at home, it can be applied at night, but it is a topical chemotherapy. So sometimes patients are concerned about pets, they're concerned about small children, people and pets who can get into this medication or who could be in contact with them. And one of the side effects of nitrogen mustard is a rash. And so even if the risk of getting that rash is small, some patients just don't want to risk trading the rash of their disease for the rash from a medication. Or they say that they travel a lot for work and taking prescription medicines through security isn't ideal for them. So there are lots of lifestyle choices that may go into choosing one treatment over the other, even for our early stage patients. So in comparison, when we think about our late stage patients, usually again, what we're trying to do is get symptom control. So maybe we start out by choosing based on which compartment is the most dangerous or which compartment is bothering them the most at that time. So maybe a patient has really big lymph nodes, for example, and those lymph nodes are very bothersome to them and we need to get them under control. So in that case, we would think about something like romidepsin. But romidepsin is a 4-hour infusion. It's 3 weeks on, 1 week off. And that may not be a reasonable option if you're trying to maintain work or you live far away from a center. So when we're looking at these late stage patients who are red all over, they're super itchy, we need to get them under control fast, we may consider mogamulizumab. And it may not be quite as good at getting lymph nodes, but it's an hour-long infusion. And initially it's pretty frequent, but then it goes to every other week. And that just may be much more compatible with someone's lifestyle and what they're able to do. So we know that mogamulizumab has been very effective for our patients, especially our Sézary patients who have blood involvement. So I want to share a case of a patient who initially did really well with Mogam. This first picture is what his disease looked like when he was initially treated. And he used to be red all over, very, very itchy. So this is actually a fantastic looking back. We loved seeing him looking like this. But the problem with Mogam is that patients can develop rashes on this medication. And like we talked about earlier, that can be a trade-off for some of our patients because even though their disease is being treated, they don't want to get a rash from their medicine. And while most of the time the rash that you can get from Mogam is self-limited, I did want to share this photo example of this patient because his mogamulizumab rash, a side effect of the medication that effectively treated his CTCL disease, was widespread. You can see it on his face, you can see it on his hands. It was photosensitive, so it got worse in the sun. And for him, it was pretty debilitating to have this rash. And ultimately, he felt like he made the wrong choice. That even though his blood was clear of lymphoma, this secondary rash, even though it wasn't dangerous to him, was impacting his quality of life in a worse way. And he's still unable to do the things that he enjoys. So this is an example of a situation where, unfortunately, the treatment did end up becoming worse than the disease. So the final thing to mention is, what do we do if our treatments aren't getting us all the way there? Your skin and your blood look clear, but you're still having symptoms. And this is the case where a quality of life tool would be helpful because it gives us a standardized way to say, yes, your skin and your blood look amazing, but you're still itching and we need to control that. And many of you have probably worked with your providers pretty extensively on this to try to control. And we often use gabapentin or Cymbalta, duloxetine to do that. But having a specific survey that asks about these specific symptoms, that's again specific to this disease, would help us more reliably identify patients that may not be willing to speak up when their symptom control is not where it needs to be. it is really hard sometimes to speak up and tell your doctor that you still don't feel good when they're telling you that you're doing well. So probably unsurprisingly, because of everything that we've talked about today, we are really worried about depression and anxiety in our patients. We looked at specific questions in our questionnaires, asking about depression symptoms, asking about anxiety symptoms. For example, I showed you that picture of the SF36 survey earlier, and one of those questions asked about depression symptoms. So we looked at our patients' responses to those questions in particular. And then we also looked at psychiatric medication use and whether or not our CTCL patients actually get the psychiatric diagnoses that they deserve. And we found that even though our patients with CTCL are reporting these depression and anxiety symptoms to a much higher degree than patients without skin disease, they're not getting the same diagnoses and they're not getting the same medications. And so we really worry about whether our patients are having so much focus on their skin disease that we're missing these other problems that result from their skin disease. So a few final conclusions here. Again, we know the impact of CTCL can be huge, not just in terms of how it affects quality of life, but also in terms of financial impact, whether we're comparing against just other skin diseases or comparing to end-stage kidney disease patients who are getting dialysis. Patients may look like they're under control, but the burden of having this chronic disease or chronic cancer continues to take a toll on them. And again, our patients may not feel comfortable talking about mental health or bringing these things up themselves. So we hope that we can catch these patients and give them the referrals and the services that they need. There needs to be an emphasis on interdisciplinary care that includes dermatology and oncology, but also integrates psychological and psychiatric services for our patients who clearly need them. At WashU, we've actually added a psychologist who's part of our multidisciplinary CTCL clinic and sees a majority of our patients automatically. And we also document a distress score as one of our vital signs. Hopefully, through researching quality of life, creating a better way to measure it in all of our patients, we can both better understand what our patients are experiencing and also use that understanding to impact our treatment decisions and get our patients the help that they need. Thank you so much for inviting me here to speak. Thank you to all of my collaborators, especially my mentor, Dr. Amy Music, our clinical team, everyone who's provided funding and support for all of our studies, and of course, all of our patients who take the time to fill out these surveys and participate in all of this for us. Thank you.
Thank you so much for being with us and for such an amazing presentation. What a wealth of information you have collected and analyzed. So appreciate you sharing it with the community. We have received a couple of questions and comments from our attendees. One comment was I have developed a lot of lymphomas since using bexarotene and also hair loss. It doesn't appear to have a question there, but just an acknowledgement of the side effects, I think, from some of the medications.
Go ahead, Holly.
Oh, no, that's fine.
And so, of course, I can't comment on your specific case, but certainly something to bring up to your physician. And what we tend to see the most with bexarotene is changes in some of these lab values. So one of kind of the dose limiting changes that we see is that we see fats in the blood increase. And so it's hard to use in patients with heart disease. And then we also see patients have problems with their thyroid, and that can also be dose limiting for us. And so while we have not seen a lot of hair loss in our patients with bexarotene, it is certainly something to bring up with your doctor because it could certainly affect the treatment decisions that they make for you.
Yeah. Thank you so much for addressing that. And then I have put for you in a chat another question. I don't know, can you see that, Doctor?
Let me see.
If not, I can read it out to you.
I'm seeing it.
Okay.
So the question is, I read about a link between serotonin reuptake inhibitors and mycosis fungoides. Are you aware of any links there? So the last thing that I read about was cutaneous lymphoid hyperplasia, which is not exactly the same as mycosis fungoides. So I am not aware of the exact study that this patient is asking about, but I would be very interested to read about it. And I'm not sure exactly what the link was in the article that they had read, but we use serotonin reuptake inhibitors quite often. Cymbalta, which I had mentioned earlier, does include serotonin reuptake inhibition, and it tends to help us with both itch and with some of the depressive symptoms. And so it would be helpful to know if there was a link there, if it is causing any worsening of disease. I would be very interested to read that.
And I did put one additional comment and or question there as well.
Let's see. So the question is, thank you. This research mirrors and validates my experience of having a major dip in quality of life since my diagnosis. One thing that I didn't see mentioned is that for those with cutaneous B-cell lymphoma, we have no experts to rely on, and even the best medical providers that we can access have given misinformation and get confused about T-cell versus B-cell. And if the experts are not clear, that's very scary for our present and our future. What can we do to improve quality of life? And I'm also interested in any B-cell cutaneous lymphoma resources that you can point me to. This is a great question because you're absolutely right. We actually don't tend to see a lot of cutaneous B-cell lymphomas. And so personally, I don't have enough experience with B-cell lymphomas to answer that question. I will talk to my mentor, Dr. Music, and see what resources she has available. And so what I'll do is actually provide those resources to the administrators of this talk so that they can be shared and disseminated on the website.
Wonderful. Thank you so much, Doctor. I appreciate that. In not a question necessarily from the audience, but just working with a lot of questions that do come into the foundation, patients frequently get requests to participate in patient-reported outcomes. How do they know when it's a legitimate source, or should they provide their information, or is it something that's actually going to be used in a scientific way to advance and further? Is there any information that you can give to the people watching to know when and when they shouldn't, and who they should ask those very important questions to before sharing personal and potentially vulnerable information with the outside community?
And that's something that we really worried about when we were doing all of our studies, particularly our interview study, because of course there's a lot of identifying information that's involved in a study like that. So I would advise always checking with your physician before you fill out these surveys online, particularly if it's being sent through your personal email address and you don't recognize the source. I think in general, if it's coming from pharmaceutical companies, if it's coming directly from an academic institution, then it's easier to see the connection between filling out that survey and how it may impact your experience with CTCL, because usually it's going towards treatment decisions and improving the quality of the therapeutics that we have. It's hard to give, a generalization about what questions you should answer and what questionnaires you should respond to. In general, what I do in my daily life is I always just check the source, make sure that it's reputable. If I've never heard of it before, then I would check with your doctor.
Thank you. That's important because yes, people come across them on social media. They come across them from all different sources, and whether or not it's potentially a marketing company or it's somebody doing some good scientific research, and we absolutely need to get the data so that it can help in treatments and then hopefully long term in the overall care and insurance and things in that nature. I have added another question there for you.
All right. I take a survey each time I go to see my dermatologist. Amazing. I also suffer from migraines as well as mycosis fungoides. The questions don't specifically state because of the mycosis fungoides, do you? I answer for the past 4 weeks, not just for mycosis fungoides. And this is a great question because, of course, we are going to have patients who have other medical conditions at the same time as their skin disease. But that's part of the reason why we like to have as large of a group as possible that we can use these questionnaires for. We actually asked all of our patients to participate in our studies. Most of them have. And once we have that larger sample size, it allows us a little bit more discriminatory ability there. It's really hard to ask patients, and it's really hard to ask doctors what symptoms are coming specifically from this skin disease versus symptoms that are completely separate from it. And of course, there are the situations where you may have migraines separately, and then mycosis fungoides is causing some exacerbation because of poor sleep or because of fatigue. So we do not ask our patients to differentiate between, do you think that this is because of your mycosis fungoides, or are you just experiencing the symptom? Because it's really not a fair question to ask.
That makes sense. And I am putting one more question up there, although I'm not 100% sure it's addressing the current topic, but if you do have information that you're able to share, that'd be great.
Absolutely. I have a very recent diagnosis of mycosis fungoides, and I've also had Graves' disease for most of my life. I'm 43. Does having Graves impact my mycosis fungoides diagnosis? That's a great question. So for those that are not aware, Graves' disease is a type of thyroid disease, and it can cause you to become more anxious. Sometimes it actually can cause rashes as well, can sometimes cause some heart conditions associated with it. It's hyperthyroidism, can also cause some ocular complications or eye complications. And so I'm not aware of a specific link between those two diseases. I would think that the biggest complication that would be there is how the Graves' disease would impact your treatment choices, because we obviously have different lab values that we monitor for different choices of therapy. As I mentioned before, bexarotene is one of the therapies that actually impacts the thyroid and the function of the thyroid. So it's something to make sure that your doctor is aware of that, because it will change the way that they treat you.
Absolutely. That is actually all the questions that we have, Doctor. Thank you so much for your presentation and taking the time to answer so many questions from our audience. If I may just give a half a jiffy here to see if anybody puts an additional question up. Doesn't appear as though they are, but do want to thank you for your time this afternoon and for your participation and for the amazing work that you're doing in your clinic. And we look forward to hearing more outcomes and how this tool becomes developed and it starts being used widespread throughout all the cutaneous lymphoma clinics worldwide, hopefully, and so that we can start really making some significant impact using patients' experiences. And for our audience, we're going to take that short break. You can pull together all your clinical Q&As for the panel after the break and be ready to come back together. But thank you again so much, Doctor, for your time, and we look forward to being in touch.